Welcome everyone to today's webinar. I am Margo Vaselli with Becker's Healthcare. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any question you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We look forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it is my pleasure to turn the floor over to Scott Becker to begin today's presentation.
Thank you, Margo, and thank you all for joining us today. We're going to talk today about CMS reimbursement of non-opioid post-surgical pain management in the ASC, a review of the new CMS rules and opportunities for ASCs. We're going to talk through 4 core content areas. First, the CMS rule. Second, the value in the ASC. Third, Medicare surgery trends. And fourth, preparing for 2019. We're thankful to Postsurgical Pharmaceuticals for being the sponsor of today's webinar. Thank you to Postsurgical. Today, we're going to work through the 4 content areas. Naya Keyes, a principal at ECG, will be the principal content reviewer and give us an update on the core of the 4 areas we're going to talk about. Then we'll have a series after each content area of Q&A with our 5 great panelists, 4 of which are on now, and 1 should be joining halfway through this. In a second, I'm going to ask each of our panelists to briefly introduce themselves, and then we'll come back and start the webinar with Naya Keyes starting to walk through the content areas. At the end of the webinar, as Margo said, we encourage questions from people. We'll try and get through as many questions as we can. We'll try and hit the core content in the first 40 to 45 minutes, so we have room for questions at the end. With that, let me spend a moment and ask each of our panelists to introduce themselves, and then I'll end with Naya Keyes introducing herself and moving on to the start of the presentation. Dr. Barber, can you say hello and introduce yourself?
Yes, I'd love to. Hello, I'm an orthopedic surgeon. I specialize in sports medicine, principally shoulder and knee surgery in Plano, Texas.
Thank you very much. Greg T. Concilius, could I get a moment from yourself?
Sure. Hi, Greg T. Concilius. My background is clinical as a assistant, worked in orthopedic surgery since about 99. Opened up a multi-specialty ASC in suburban Boston in 2004, orthopedics and pain management primarily, and happy to talk to you about our use of Exparel over the last couple of years.
Thank you so much. Lisa Rock.
Hello, everyone. I am president of National Medical Billing Services. I've held this position for about 15 years and specialize in ASC billing, coding, reimbursement.
Thank you, Lisa. I know you've grown a large company around billing and coding for surgery centers. We're thankful for you joining us today, as well as Alan and Greg, who've done magnificent things professionally. Matt, you're with one of the largest surgery center companies. Would you take a moment and introduce yourself too?
Sure. Thank you, Scott. This is Matt Pate. I'm a senior vice president with United Surgical Partners. We, as Scott mentioned, we manage short-stay surgical facilities all over the country in partnership with local physicians. Been with the USPI for about 20 years and been in my current role over our service line development and expansion since 2013.
Thank you, Matt, and thank you all for joining us. Naya, let me ask you to introduce yourself, and then if you could introduce the topic of the CMS rule, that would be terrific. Why don't you start with introducing yourself and then the CMS rule?
Absolutely. This is Naya Keyes. I am a principal from ECG Management Consultants and the ambulatory surgery practice leader for the firm. And today I'd like to go over the learning objectives and then get into the CMS rule. We've got some faculty disclosures first. I apologize. The faculty have consulting relationships with Postsurgical Pharmaceuticals. The program is not accredited for continuing medical education, and attendees will not receive CME credit. This program is sponsored by Postsurgical Pharmaceuticals. So the learning objective. Oh.
Go ahead. Thank you.
You're welcome. The learning objectives for today are the information and education on the CMS rule authorizing separate reimbursement for Exparel, perspectives on significance and value from ASC stakeholders, Medicare surgery trends in HOPDs and ASCs, and opportunities with reimbursement access to Exparel, and guidance on preparing for billing with HCPCS code C9290. Also, information and resources to learn more about Exparel and reimbursement through HCPCS C9290 can be found at exparel.com/reimbursement. So moving on to the CMS rule. Under the new CMS rule, Exparel is eligible for separate payment in the ASC setting effective January 1, 2019, when billed with HCPCS code C9290. It is important to note that Exparel is indicated for single-dose infiltration in adults to produce post-surgical local analgesia and as an interscalene brachioplexus nerve block to produce post-surgical regional analgesia. Safety and efficacy have not been established in other nerve blocks. There are two doses, 133 milligrams and 266 milligrams. I want to talk now about the site of service with respect to the CMS rule. The payment is eligible for Medicare certified ASCs only. So those would be surgery centers that are Medicare certified and have access to Medicare reimbursement. Acute care hospitals, HOPDs, and hospital-based same-day surgery centers are not eligible for separate payment. The ASC reimbursement rates are at $1.20 per milligram, and again, the Exparel doses are at 133 milligrams, which would reimburse at $159.30. And the second dose is at 266 milligrams, which would reimburse at $319.20. The population, again, is for the Medicare population, and eligibility starts January 1, 2019. Access to commercial patients and reimbursement rates vary, and it is subject to commercial payer contract terms and methodologies. Therefore, it is important for ASCs to review their commercial contracts and to also speak to the payers to determine whether or not they will have eligibility for Exparel and what the timelines may be on that. They will vary by commercial payer. So moving on, I want to hand it back over to Scott, who will have some questions for our panelists.
Thank you very much. We've got 4 questions we're going to work through with our panelists. And Dr. Barbara, let me start with you. How does the availability of a non-opioid, long-lasting post-surgical pain management option impact your surgical practice? I mean, there's been so much discussion about the challenges of the opioids. How does this impact your practice, and what are some of your observations on it?
Since I started using Exparel as my injection of choice sometime in 2015, I've found a remarkable decline in the amount of opioid requirement for my patients, to the point I've gotten to addressing this up front with my patients, saying that I have an opioid sparing or opioid avoiding surgical practice. And in fact, I'm able to do that with patients being completely controlled with a multimodal pain medication program, which includes gabapentin, meloxicam, and Tylenol for about 3 days. Many of them will have significant surgical procedures and not require any opioid for breakthrough pain. And I think that's healthier for the patient and reduces the risk for everybody concerned.
Thank you very much. And let me ask Greg and you the following questions. What types of surgeries are best suited for Exparel in an ASC? And Exparel being the non-opioid type pain management option. What are the best surgeries that are suited for this? Greg, do you want to start on that?
Barbara,
and then we'll go to Dr. Barbara.
I can talk a little bit about our experience. So we were actually introduced to this drug a couple of years ago. We have a orthopedic surgeon, who does some complex multi-ligament knee reconstruction, some big osteotomies, and he introduced it to us and asked us to get us on the formulary. Now, of course, cost at the time was very, very, it made it very, very restrictive for us. And at the time, we added it to our formulary. However, for the select surgeon, these select procedures. Now, it really came to light when we developed our joint program, and we introduced it as one of our solutions for post-op pain management and kind of part of our clinical pathway. And so for us then, that's when it became more of a common usage. Of course, cost was still the issue until now, which we'll talk about today. So that's kind of where we're using it though. Big, we haven't used it for open hernias or anything like that yet. Knee reconstructions in joints.
Thank you. And Dr. Barber, do you want to comment on where you see it being used?
I started out using Exparel for ACL reconstructions and rotator cuff repairs. And then as my experience grew and I got more and more confident in its actual effectiveness, then it expanded to every shoulder, whether it was a rotator cuff repair or instability or just a decompression. And then now I'm using it on all cases, including simple knee scopes. We don't have to use as much for the simple knee scope as we would for a bigger case, but I think everybody benefits. My typical protocol is to use a local anesthetic to prepare all the portal sites, and just mixing that with Exparel means that this thing is going to last for a much longer period of time than just plain bupivacaine.
Thank you. Let me move to a different question. So both you and Greg in your facilities using this more and more as an alternative to opioids and having results you're comfortable with are great results. Lisa, an important question for many people is how do you bill for this? So what do providers and administrative staff need to do to bill for Exparel using code C9290 for Medicare? Lisa, can you talk about that?
Sure. Surgeons must document the use and the dosage in their operative report. And of course, you're going to bill using the HCPCS code C9290 and either the 133 milligrams or the 266 milligrams. And you're going to bill those as units. On the 1500 claim form, you're going to populate that in box 24G. But documenting the use and dosage is going to be critical to getting this billed and paid for.
Thank you. And Matt, you run a national chain of facilities, a large chain. When did your ASC start making Exparel available and why? And then Greg, the same, coming back to you on this question, when did you start using it too? Matt, do you want to kick off on that?
Yeah, sure. So in 2011, Exparel obtained FDA approval, and we started seeing requests in 2012, and we really saw them pick up in 2013. Both our ambulatory surgery centers as well as surgical hospitals. The physicians really drove the utilization, and what we saw was mostly orthopedics, started with joint replacements, general surgery with bariatrics and hernia, and we've now more recently seen, a fair amount of Exparel being used on some spine cases.
Thank you. And Greg, did you want to comment as well?
Yeah, no, just as I mentioned, it was introduced a couple of years ago, and we got on the formulary since then, but only became more kind of commonplace with the joint surgeons and our joint replacements, and it's really surgeon dependent. So we don't use it as on every joint. We use it as part of the surgeon's choice for their clinical pathway and their multimodal pain management. So we've now kind of expanded use to patient selection, patients with chronic pain or pain management issues, and again, these larger procedures. So maybe unlike Dr. Barber, we're not using it as commonplace now on every procedure, but I see it kind of going that way down the road, now with the reimbursement changes, et cetera.
Thank you. So just to briefly summarize, first point is that CMS rule now allows us to be eligible for separate payment in the ASC setting effective January 1st when billed with HCPCS code C9290. And just really what we've heard from Lisa is sort of the clarity of needing to document what you're doing and how much you're using and so forth. And we've heard from Dr. Barber, Greg DeConcilius, and Matt Pate is just the growth in the use of it and why they're using it in their facilities and so forth. So thank you very, very much. Naya, I'm going to turn it back to you to provide the starting content on the value in the surgery center.
Great, thank you, Scott. Value in the ASC. Reimbursement for Exparel allows greater patient access to an opioid-free option for post-surgical pain management in the ASC. And we've heard, from our panelists, obviously that momentum for value and expanding use is growing, and it continues to grow. Exparel has been clinically demonstrated to significantly reduce opioid use while achieving effective pain control. Opioids are associated with a range of side effects that can impact achievement of recovery milestones and patient experience. Financial considerations or supply cost concerns to use Exparel on Medicare patients are now eliminated. The CMS Rule provides the necessary momentum for commercial payers to follow CMS's policy, which is aimed at supporting the use of non-opioid-based post-surgical pain management in the ASC for Medicare patients. I want to point out that one of the national payers, Aetna, has recently launched a pilot program in Florida and New Jersey where select ASCs will be reimbursed for using Exparel to incentivize non-opioid therapies for post-surgical pain management. And I think that if you are, again, looking at your commercial payers, many do follow Medicare policy and or Medicare payment methodologies. And we're optimistic it will just be a matter of time and ensuring that the ASC is in communication with the commercial payers to determine what their process will be for implementing change. So I would like to turn it back over to Scott, who to discuss some questions with the panelists on value in the ASC.
Sure. Thank you very, very much. Let me start with, again, Dr. Barber, our orthopedic surgeon on the call. What's your experience, Dr. Barber, with patients that are desiring the option for a non-opioid alternative? What's the experience you're having with patients? How do you talk about it with patients? What do you hear from patients? Is this a common request today, just with all the dialogue nationally around opioids? Give us some of your feedback on direct patient encounters with this.
As part of my standard description of what the procedure entails, as I mentioned, I state that I'm opioid sparing or opioid avoiding in my surgical approach. And I think that has resonated with my patients well, not only from a clinical perspective, but it also has an advantage from a marketing perspective. I haven't really started using a website or a Facebook page to tout opioid-free surgery, but I know that there are some who are doing that quite a bit. In the Dallas area where I practice, I think patient awareness of an opioid crisis is not really at the top of their list of concerns when they come to see me. There are occasional patients who are in recovery for drug and alcohol issues that will mention that to me, and they are very appreciative of trying to do everything they can to avoid sticking their toe in that pool again. So I think it's an ongoing concern for a lot of people. It may not be talked about much, but it's one of those sort of hidden secrets that people don't talk about.
So you would look at it and say, three or four things I heard you say. It's very acute for some patients, particularly those that have had some experience or bad experience in addiction, and they're very concerned about it. The vast majority of the patients, at least in the Dallas area, are not so focused on it, though beneath the surface, everybody's more and more concerned about being on opioids with the concerns about addiction. Third, even though you really push to be opioid-free as much as possible, you don't separately promote this via a website or other types of tools that you're opioid-free as you try to be opioid-free in doing surgery, but you are aware of some that do. So thank you. And then, Dr. Barber, a follow-up question. Specific to Exparel, what's your experience with patients desiring and reviewing and receiving Exparel?
I don't think I've had a specific patient come. Yeah, I don't think I've had a specific patient come in and ask for Exparel. I don't think they're that sensitive to this particular brand or the concept behind the delayed extended release drug. But when I talk to them about it, they're really excited about it, and it's very common after surgery for them to say, this stuff is great. I haven't had any pain at all. It's amazing.
Got it. So it's less at this point brand awareness and much more you have patients that are ultimately pleased to not take the risks of addictions that could come with opioids and so forth. That's more how you'd look at it today.
That's correct.
Thank you. And let me ask Greg and Lisa a question in the area of billing for this on the commercial side. Medicare has set a rule that's approved separate payment for non-opioid drugs such as Exparel in an ASC, but that doesn't mean commercial payers will, but it's always a leading indicator that they may at some point. Greg, any observations on what you expect from commercial payers? And then Lisa, really the same question with you.
Yeah, and Lisa obviously, I'm interested to see what she says, but from my experience, I'm the president of our state association, and we're constantly meeting with the insurers and trying to, work on different reimbursement methodologies. And what we've seen is that they always follow CMS, and I think it's going to be the same thing here, with the exception of, they usually follow CMS and they take stuff away from you as opposed to adding stuff on. So my advice and the route we're going to take is to make sure, first off, we're in front of the right people. So oftentimes we deal with, or if you're anybody who's on this call, you deal with an admin person, if you will, from a different insurer. So we're going to try and go to a higher level person and try and get some kind of medical personnel. That's kind of how we've had the best success. And so prior to the meeting, we'll provide them with some information on the drug, kind of what its effects are. And me being in Massachusetts, it's a little bit easier because our governor is so against opioids, and there's so much push to be opioid free that this will play right into kind of what everyone's looking for. But anyway, we'll meet with the most appropriate person, again, the highest level person we can, and say to them, listen, you followed CMS before. This is obviously good patient care and something that we'd like you to follow here again, and we'll see where it goes. But that's usually the tactic we take: a face-to-face meeting and kind of providing good information, with the right people.
Thank you very much. So you really have to tie that together. When your state is very pro reducing the use of opioids, but you really have to tie it together with face-to-face meetings and working with the payers to get there on commercial reimbursement, is what it sounds like. And Lisa, as Greg said, we'd love to hear your observations on this as well.
Well, I have some good news. Some of the local Blues plans are already allowing for this. It's on the fee schedule at a rate of $1.36 a unit up to $5.16 per unit. Now that's way up north in a high rent district, but we're seeing some of the local Blues at that $1.36 to $2 range per unit. And as Naya mentioned earlier, Aetna has approved payment for select surgery centers. We do not see a fee assigned for the enhanced ambulatory payment group. So any payers that are using EAPG as a reimbursement methodology, we do not see a fee assigned with that. And we do not see an approved fee for UHC or the Big Blues or Cigna today. But I agree with what Greg said, that I expect most of these to follow Medicare as we go forward.
So to summarize, value in ASC, very positive feedback from patients who are looking for a non-opioid alternative, and more are. And then in terms of commercial reimbursement, it's a work in progress. And often when Medicare starts to reimburse things, that's a good indicator, but still not there with some commercial payers. But at least as for Medicare, payment will be available in the ASC setting as of January 1st, 2019. Naya, I didn't know if you had any comments on that issue of commercial reimbursement, or if just wanted to move right on to the Medicare surgery trends content slide.
Sure, I can just add a few more words. As Lisa said, there are already payers that are probably moving forward or have established fees based upon their methodologies. If your payer contracts, if an ASC's payer contract is based upon Medicare, and it explicitly stipulates that in the payment section of the contract, the likelihood of your ability to access reimbursement in 2019 will be extremely high. However, it does take some time for commercial payers to update with Medicare. So if you have a commercial contract where your payment methodology is based upon current Medicare, the incident rate or the expectation of them adopting it quickly is going to be extremely high. There are also payers who follow, as Greg and Lisa both said, CMS policy. So even though they don't follow the methodology, they follow the policy. And so it will just be a matter of time for them to implement the policy. So if ASCs learn that it's not, going into place right away in January, it will be important for them to follow up periodically and also to educate the payer about the fact that CMS now has approved it, because that will help many times to move them along.
Thank you very much, Naya. Let me do this. We're halfway through our core content. Thank Pacira Pharmaceuticals briefly again, and Naya, let's move it right back to you on Medicare surgery trends.
Okay, great, thank you. On Medicare surgery trends, post-surgical pain management is a key consideration. When choosing surgical procedures performed in an ambulatory setting, many surgery centers do, different types of surgery, and obviously it depends upon the surgeons and their capabilities and their equipment and so forth, and their staffing. Exparel has a broad indication for infiltration across all surgical procedures. An expanded indication also includes interscalene brachial plexus nerve block. In the chart on the screen, you will see on this screen three different things. This is an evaluation of hospital outpatient department Medicare utilization of some key surgical procedures, not all, but some key surgical procedures, and ASC utilization from 2014, 15, and 16, and then the total combined, and this is Medicare only. And so as you can see, there's quite a few, surgeries that, one, are being done in the hospital, but then have also migrated over to the ASC or are migrating and growing. And many of these may be surgeries that Exparel would prove to be beneficial to the patient. So, it's important to, look at these, and obviously there's more surgeries, but to evaluate what those trends are, because there's quite a bit of surgery here going on in the Medicare population, that, may present opportunity to offer a non-opioid option, of Exparel. So with that being said, I wanted to turn it back over to Scott to review some questions with the panelists on Medicare surgery trends.
Thank you very much. And Dr. Barber, let me start with you again. Do any of the trends with Medicare patients stand out as procedures that can benefit from having the option of a non-opioid post-surgical pain management alternative?
Well, in my space, it would be the shoulder and the knee cases, the sports kind of cases, including rotator cuff repairs, and those are really increasing. I've become more comfortable doing rotator cuff repairs in the ambulatory surgery center, as well as doing ACL reconstructions in that center, and the use of Exparel has really facilitated that, because the stress to the patient is less, and of course, if you select your ASA rating properly, you're not going to have difficulty with those patients. Some of my colleagues are doing total shoulders in the ambulatory surgery center environment, and if you can do something that would be outpatient surgery in a hospital, you could certainly do it in an ASC.
And you answered this in part, but the sort of follow-up question is, how much does post-surgical pain control affect the site of service that you choose? And is it any different with Medicare patients, because you're dealing with just a little bit older population than the average population? So how much does it impact your site of service having the non-opioid pain control option? And then is it different for Medicare patients versus commercial patients?
Well, the Medicare patient, of course, is more challenging than the non-Medicare patient, because they're older and they may be more frail. The way I've sort of done this is to keep an eye on the time patients require to stay in the step-down unit than before they get sent home. And if my patients are spending 60 or 90 minutes post-surgery before they're sent home, then I think that's a good indication that they would do well in the ASC. And since we've been using Exparel liberally for the rotator cuff repairs and the ACL repairs, not that you see that a lot in the Medicare population, but I feel more and more comfortable moving them into the ambulatory surgery center environment.
Thank you. And then, Matt, similar question. When you look at this nationally across your 300 facilities, 250 to 300 facilities, does access to Exparel, or just non-opioid pain management medications, does it help impact migration of surgical cases from the hospital to the ASC? Any observations on that, Matt?
I think, at least for us, it's unquestionable, without a doubt, that it has impacted. The enhanced recovery after surgery protocols, the ERAS protocols, have certainly accelerated the migration of cases to the ASCs, particularly cases like joint replacements, whether it's Exparel or even a multi-drug cocktail, for a long-acting paracapsular injection done intraoperatively has really been effective in enabling these cases to migrate over. We also saw, we also experienced some cases in which physicians became frustrated at the hospitals that they were at. Hospitals, because of cost, would not allow some of these, like an Exparel, on their formulary. And as a result, some of those cases came over to our facilities just simply because we were willing to allow it to be on the formulary, and this change makes it even more beneficial.
Thank you very much. Let me do this. I think, Dr. Barber, do you have any final comments on the migration of cases from inpatient to outpatient as impacted by Exparel or similar non-opioid treatment?
The hospitals tend to want you to migrate cases that aren't going to be reimbursed by the insurance companies from the hospital to the ASC. And I think the fact that the surgeons are more comfortable with that, since Exparel is available to be used, is going to just speed that process up.
Thank you. Naya, we've talked briefly about the migration of cases in Medicare surgery trends, and a little bit about which cases may be most best suited for the movement to outpatient based on a non-opioid treatment alternative. Do you want to take this back and talk about preparing for 2019 now? And then we'll come back to our panelists for some questions about that.
Sure, absolutely. So in preparing, thank you, Scott. So preparing for 2019, reimbursement again will be available for Medicare patients using Exparel starting January 1, 2019, if billed with HCPCS code C9290. It's really important that you review the case types that may benefit from Exparel use in the ASC. We've heard a lot about orthopedic cases, shoulder repairs, knee cases, hernias, but there's a laundry list of procedures, breast reconstructions that may present opportunity for offering the alternative. So it's important to review that, with your surgeons and ensure that they have the education about the reimbursement access as well, because it may also present opportunity, as we just talked about, for new cases to come to the center. Consider those patients who are being prescribed narcotics to manage pain post-discharge. Those are obviously things that, your physicians are going to be really interested in and in having conversations with the patients. Educate providers and Medicare patients about the coverage for Exparel. It's very, very important that providers and patients are educated. They don't always know when the rules have changed, and so providing information will be very helpful to them if the ASC can do that. And we've talked a lot about the importance of contacting commercial payers to determine if the payer will allow for reimbursement in light of the CMS rule for Medicare patients. Again, I want to stress that may not happen on January 1. Many commercial payers have lag times on implementation. But it can often be very quick. It can be within 30 days, or 45 days after January 1. It takes sometimes some administrative time for them to load updates. So it's really important that, you have somebody in the business office at the ASC who's responsible, for following up, with the commercial payers to determine, if they've told you they're moving forward or their methodology is based on this, what is the timeline? What is it effective? If they're going to retroactive back to January 1, which is not typically common, but some may, that will be important, especially those with Medicare Advantage plans as well. So Medicare Advantage plans typically will follow suit right away, and so that will be important, for you to check if you've got commercial payers that are also administering and managing Medicare Advantage plans. So, with that being said, I want to turn it back over to Scott, who's got a few closing questions for the panelists.
Great. We do have a few closing questions for our panelists, and then we have a ton of audience questions we're going to try to get to within 5 minutes. So we'll try and move this along here, which is great. For Matt and Greg, the biggest opportunities that your ASCs have as a result of allowing separate payment for Exparel. Matt and Greg, what do you see as the biggest opportunity? And then we'll talk to Dr. Barber about best ways of communicating this, and then to Lisa about a couple questions relating to reimbursement. Matt, can I turn it to you for biggest opportunities, and then Greg?
Sure. I'm very optimistic, although I think keeping expectations probably in check. I'm not expecting sweeping changes, but this should certainly allow us to improve reimbursement on the cases, the Medicare cases that are being done. We'll work aggressively to try and get commercial coverage as soon as we can. I do think it'll also allow us to capture a few more cases that have historically not been done, because either the physician or the facility shied away from doing the case because of reimbursement cost issues. So I think it'll help improve the margins. And equally important, I think, as mentioned earlier, I think this will definitely help improve some of the patient satisfaction and some of their outcomes by the use of this type of drug.
Thank you very much. And Greg, did you want to comment on that as well? Biggest opportunities that you see as a result?
Yeah, I'll try to make it brief. I did
payment?
make a couple of points, but and I'll echo some of the stuff Matt said. But I'm thinking if someone's on this call, as I would be as an administrator, you either have heard of someone approached the drug to you, one of the surgeons wanted to use it, or maybe you're already looking at migrating new cases where this would help you with your overall, again, clinical pathway and utilizing it for patient care. So I think you got to look at the opportunity is really, really high with this. If that surgeon did approach you about using the drug, I would ensure that your work to get the drug reimbursement straightened out, now from your commercial payers as best you can. And then, you may even want to, take the chance to start having recruiting the surgeon to come over and utilize the drug, maybe taking a hit, knowing that hopefully it'll come down the pipeline where you get reimbursement for it, but, get them comfortable with the center like you would normally with, recruiting a new surgeon. But, the surgeon, there's a chance they may not be able to use that at the hospital. So now it's available at the ASC, maybe you'll bring him or her over. We already talked about the new cases, the joints, the spine, all that kind of stuff. That opportunity obviously is tremendous, and we all know it's the hype if you go to any of the major conferences. I think you also should be looking at if you're using pain pumps and interscaling, pain catheters, there's a significant cost to that. I'm sure you're not getting reimbursed for it. I don't think you are. And so is that something you can be, replacing with a drug that you can potentially get reimbursed for over time? Matt talked about higher patient satisfaction, but I mean, we've seen this with our joint program tremendously. I think, the fact that we've had no readmissions for pain control, not that we're using it on all of our drugs, it's surgeon, all of our cases, it's surgeon dependent, but no readmissions, really tremendous. But obviously, having them be pain-free, that's really, really important. I'll give you a quick stat. So we started looking at the use of it with our interscaling blocks. We've done it with 8 patients. And again, this is totally independent, so there's nothing to do with Pacira, but we had 58.75 hours of pain relief from those blocks for our 8 patients we've done so far. We're ongoing with our interscaling blocks. And so that's a tremendous opportunity down the road. Dr. Barber already talked about bringing some of these shoulder surgeries over, not only joints, but regular straightforward cuffs and complex shoulder reconstruction. So that's obviously a big piece. And the last piece we talked about briefly was the marketing opportunities. And as patients become more and more savvy regarding opioids and opioid abuse, which they already have in our area, can you market this to patients on your website? Can your surgeons market it in the office and that type of stuff? So I think, again, the opportunity is pretty tremendous.
Thank you, Greg, very much. It's good to hear your enthusiasm for it. It's fantastic. Just great. Dr. Barber, any quick thoughts on communicating this to patients? Any quick thoughts on that?
We do this extensively at the time of the scheduled surgery. Part of my disclosure and counseling to the patients include the postoperative program, and we go into it in pretty good detail, why we use the Exparel and what they can expect. And if you set the stage for the patient to expect much less pain, especially if they've had a previous surgery, say that pain that you had on the last case, you're not going to have it this time. And then when my physician's assistants do the pre-op visits and they talk about the multimodal pain medication program that we follow, they have another opportunity to go over it. So from the very beginning, my interface with the patients and then the physician's assistants interfaces with the patients, they're led to expect that they're going to have a much different experience than they may have thought they were going to have. Quite frankly, the hospitals around here are using Exparel, allowing us to use Exparel for the sports medicine cases because the competition demands it. I stopped using pain pumps in 2015 and switched to Exparel. And the cost difference isn't that much when you figure out how much a pain pump costs too.
Right.
Fantastic. Thank you so much. Lisa, I want to ask you one final question, and then I'm going to move to our audience questions because we have so many of them. Seeking approval for reimbursement with commercial payers for Exparel, what advice do you have for ASCs, Lisa? And then Greg, I'm going to come back to you when we get into the audience questions rather than calling you here. Lisa?
Sure. Well, I think you need to have your complete contracts in hand, your commercial contracts, and then check your specific payer fee schedules online to see if there's already a fee loaded. Like I said, in some cases, there is a fee loaded for this drug, and of course you bill and you're reimbursed by units in the 2 different doses. Next, you're going to call your payer rep and establish that dialogue with them to discuss what the plans are for getting this reimbursed in the near future. And that would be my advice right now. That's what you could do. Start working on all of your contracts and working with your reps right now.
Thank you very much. And Lisa, the first question I have is going to go towards you, and that is is the reimbursement, or maybe Naya, or you can answer this, is this reimbursement only when Exparel is used or other types of medications covered, such as Ropivacaine, or does this just apply to Exparel?
This is
the new rule, and I'm not sure. Go ahead.
Yeah, well, I'll let Naya. I'll let Naya answer, and I can follow up if there's anything else.
Thank you. Naya, I'm not sure if you know the answer to this question, but one of the questions posed was, is this new reimbursement only applicable to Exparel, or does it apply to other medications covered, such as, I don't pronounce it correct, so excuse me, Ropivacaine?
At this time, Exparel is the only drug that qualifies under the rule. that is was stipulated in the final CMS rules as well. So, but there could be others, that come into play. But this time, it is applicable to Exparel.
Thank you. And Dr. Barber, let me ask you this question, and then maybe I can get Greg or Matt to comment on it as well if they can. What were you using in your ACLs and rotator cuffs before Exparel, and are you using any narcotic directly in joints now? Dr. Barber, did that question make sense? Do you have that?
Yes, it does. I don't use narcotics intra-articularly or associated with the surgical procedure itself. Something that I do, that would be a postoperative pain medication issue. What I was using a combination of bupivacaine and lidocaine, and I would use that combination to infiltrate all the portals, and I would use it to leave a bolus up in the intact bursa. That would be making sure that you had a watertight seal on your rotator cuff, but would not put it into the glenohumeral joint because of concerns about chondrolysis. In the knee, it's the same story. You don't want to leave anything like that long term in the knee joint, but you would do an extensive infiltration of the area, kind of a regional block, an area block, and that would start up at the top above the patella and go on both sides, and then in the area in the tibia where you put your tunnel. So I know some people use femoral blocks and then they move to adductor canal blocks. I don't use either of those because I think that with the Exparel we're able to get a good enough area block that patients aren't having much in the way of pain. I had an ACL that I did as an outpatient that only required 2 OxyContins in the first week after her ACL reconstruction. Everything else was covered by the Exparel and the multimodal pain medication.
Thank you. Greg, let me ask you a question, and then I'm going to move to Greg and Matt on a different question, and maybe Greg or Lisa could comment on this. Are you using the C9290 code with private insurance as well? Greg, can I ask you that question, and Lisa, yourself as well?
At this point, and again, I think our plan will be to start to do it, after the first of the year. And we, again, not with other insurances at this point. We're only at the table, or we're going to start to be at the table as far as reimbursement goes with the commercial payers.
Thank you. And Lisa, same question. I take it it's going to be the same answer, but the actual use of the code. Go ahead, please. Thank you, then.
Oh, yeah, we're using the code. We've been billing it out for out-of-network. We've been billing out for those few carriers that do have an allowed amount on their fee schedule. So, yes, we've been billing the C9290.
Thank you very much. And Matt, let me ask you this question. The growth of Medicare patients in the ASC setting, are you seeing a lot of growth in Medicare patients in your ASCs? Yes or no? And then if so, what accounts for that growth? Any thoughts on what you see across your universe?
We are seeing, we are seeing a growth. We see growth in all of our cases, but we are seeing a growth in the Medicare cases, and we are seeing a slight percentage shift in that we're seeing a few more Medicare patients as a percentage of our overall population versus the commercial. And, we attribute it mostly to just the growth in Medicare beneficiaries and new ones coming in, and then the aging of the others. Don't know that we have any empirical evidence pointing to where, what's driving that trend, but we are seeing an uptick, and we've seen it for the last few years.
Gotcha. So you're seeing it for a variety of reasons. Part of it's just the aging of the population and more people being eligible, more people needing surgery. Part of it's the greater ability to do safe surgeries for people 65 and older in surgery centers. But it's not a drastic change in your case mix at all. It's not like you're doing a ton more cataracts at USPI centers at all. It's just the gradual aging of the population, and probably the less commercial payments available for certain things have led to a slight percentage movement in, and I don't want to put words in your mouth, into the Medicare population, but it's not as though surgical technique changes or drugs have made a huge difference, so they've made it easier to do older patients in the surgery centers. Thank you. Naya, I want to come back to you on one question, and that's the question about a comment on billing of Exparel to commercial patients. I mean, you do more hardcore managed care contracting negotiations than almost anybody in the country for surgery centers. Did you have a comment on the billing of Exparel to commercial patients?
Yes, absolutely. Exparel is going to be something that is important to bill when you're allowed to bill it to the payer. It is similar to implants. If a payer doesn't cover an implant, if they don't see that you're billing it, they don't know that you're using it. And so in the process, what I would call the next year of transitioning and trying to get payers to pay attention to it, it will be important to bill for the use of Exparel if you are using it. Now, from time to time, there are payer contracts, language, and things that don't allow you to bill for certain things, so it'll be important to look at that. But if there is no prohibition from doing that, the ASC is highly encouraged to do that. Otherwise, when you go to the payer and talk about how you want to get paid for it and you're using it, they're going to state to the ASC, they'll typically say, well, we don't see any utilization, so we don't see this as a problem. And when they see the utilization and then they're not paying, and you can use the discussion points and demonstrate how Medicare is allowing it, it typically will help progress the conversation with the payer. So the ASCs are encouraged to bill when they're using it, unless there's a contractual limitation.
Thank you. And I've got a question. Maybe Dr. Barber is the right person to ask this question of. Is Exparel only really useful for post-op pain after open surgery? And I think what this person means by not open surgery is interventional pain management injections and procedures. The other place I hear people talking more and more about non-open surgery is when they talk about robotic or very minimally invasive surgery versus open surgery. Dr. Barber, any comments on the use of Exparel in open versus non-open surgery?
So what I think of open surgery is non-arthroscopic surgery. And for instance, if you do a rotator cuff, you can do it through a deltoid splitting incision or a mini open, or you can do it purely arthroscopic. And in my practice, that's what I do, just purely arthroscopic techniques. And so we don't have an incision to, inject it. So what I do is a field block where I use a spinal needle and go out in a fan shape area all the way around. Now I am also inclined to do a suprascapular nerve block myself, as well as a lateral pectoral nerve block using Marcaine, because Exparel is not authorized for that kind of injection. But the combination of that makes my patients very comfortable during surgery. They experience less pain. They require less narcotics. They have a lower risk of nausea and vomiting post-op. So I think that preemptive anesthesia like that, local anesthesia, is very helpful, whether it's open or closed.
Thank you. And Naya, let me ask you this question, and maybe you could answer this. This rule seems to really encourage the use of non-opioids in the surgery center. Is there a similar movement or allowance in the hospital, or is it always allowed in the hospital? It's just a matter of because it's included in the hospital rate, the hospital choosing what drugs they're going to use. How does this work in the hospital setting versus a surgery center setting? And is there similar efforts to encourage use of Exparel and non-opioids in the hospital setting?
That's a great question, Scott. A little bit of history there. When Exparel was first on the Medicare list as a pass-through drug, it had a payment rate, and CMS did some studies, and it's outlined in the rules relative to the utilization of the drug in both the hospital and the ASC setting. And when it was a pass-through, it was paid in both settings. And when they removed it from when they changed the payment status indicator, which means they removed the reimbursement for it, they saw a significant decline in utilization in the ASCs, but not a significant decline in hospitals. So when you review the CMS ruling and all of the background information, those studies are clearly indicated. And so, there's some, when you evaluate that, there's some implications there that, they saw a drop off, they didn't want to see a drop off. So enabling access was important to cover the cost. And, but there's absolutely, indications for it being used in the hospitals, but Medicare currently does not have it on, with a payment status indicator for separate payment. It is packaged, under Medicare.
Thank you, got it. So it's not that they're discouraging it in hospitals, it's that the package there, but here they're specifically allowing and encouraging it in surgery centers. Great answer.
Right.
Thank you for the history. Matt and Greg, let me ask you this question. If you can answer briefly, we've just got a few minutes left. Spine procedures. I know across the USPI universe, a ton of spine procedures. Greg, I'm not sure if you're doing spine in your center. Exparel use with spine procedures. Any quick comments from Matt or Greg? And then I know, Dr. Miller, you joined us at some point in the call. I'd like to just ask you one or two quick questions as well. Matt, can you talk about spine procedures in Exparel?
Yes, we don't see a lot of Exparel use in with our spine cases, but we are seeing an uptick in that. We are seeing growth in that, particularly in the fusions. But yes, we see some of that, and it's increasing. Not a ton.
Thank you. And Greg, do you want to comment on that real quickly too? Do you see it in your spine
same thing
procedures?
here. We're just kind of starting we've done microdiscs for a couple of years now, and we're not using it for that. Again, probably just because the surgeon doesn't know it's available. But I think as we go down the ACDF route, we've only done one, and we start with our spine program. We have a couple of spine surgeons coming in. I think it'll be an uptick of use as well. But again, at this point, not much at all.
No, but that's a great answer. It's probably an evolutionary area and helpful for people to hear, and thank the audience member for the question. Dr. Miller, real quick, you joined the webinar. Just a couple moments on the use of Exparel in your practice and non-opioid pain management applications. Just a real quick on some of the evolutions, and thank you for joining.
Yeah, and first of all, let me start by apologizing for my tardiness. I was at the mercy of the OR schedule today. But in my practice, I find it particularly useful, especially in the ambulatory setting for these cases. I like it particularly for large hernias, particularly ventral abdominal hernias or incisional hernias. Cases where there's a lot of dissection, especially of the abdominal wall. Those patients tend to experience significant amount of discomfort postoperatively, and I want them going home feeling well, because when they do go home, I think gone are the days where we want our patients, where we say, just go home and get your rest. I want my patients up. I want them walking around. I want them active. I don't want them coming back with blood clots, pneumonias, or any of those other issues. But in order for them to do that, I have to make sure that they're comfortable enough to do that. And of course, we know that just loading them up with narcotic medications is not conducive to recovery. So mostly a lot of hernias, inguinal hernias, I will use it as well, especially if they're large. If I suspect maybe a pantaloon type of hernia. Sometimes I will even use it with laparoscopic cholecystectomies, where I put my 12-port. If it's a large gallbladder and I really have to enlarge either the fascial incision or the skin incision, and maybe I'm creating quite a bit of torque trying to get the gallbladder out with some kind of instrument. Those patients, that's very real pain and discomfort that they have postoperatively, so I will use it in those situations as well.
Thank you very, very much, Dr. Miller. Great to add some more depth to the conversation about where this is being used. Let me do this. We've got to wrap up because it's at 1 o'clock. I want to thank our audience, which stayed with us for almost the entire call. So thank you very, very much for joining us. I want to thank, of course, Pacira Pharmaceuticals for really being the driver behind Exparol and such an important area, the growth of non-opioid pain management options. So thank you to Exparol. Then I want to thank our panelists and ECG, Naya Kies, of course, who drove a lot of the content, but then just as importantly, our 5 panelists, Dr. Alan Barber, terrific, and thank you, Greg DeConcilius, who just is a tremendous wealth of information about all things related to orthopedics and surgery centers and has been a pioneer in the industry and just fantastic. Thank you, Greg. Lisa Rock, who just is the president of one of the great success stories in surgery centers and billing, is president of National Medical Billing Services. So thank you, Lisa. Brent Miller, who just joined us, who's got a fascinating background as being now a surgeon, was a coder in an earlier life, and congratulations. What an amazing story. Dr. Miller, thank you. And Matt Pate, who's been with USPI for a long time and has led up for some period of time the orthopedic and spine area, now is a senior vice president and leads up their physician strategy group. And again, just a wealth of information and great to see your insights on how you really see this working across the universe of your centers. So I want to thank everybody and of course, Pacira again. And that's all we have today. If people want to follow up with Pacira, they've left some resources on the last page of the slide. Naya Kies as well, or any of the panelists would be open to discussions, I'm sure. And if you want to be able to reach them, feel free to reach out to Becker's Healthcare, and we'll try and get you in touch with our panelists without overwhelming our colleagues, Dr. Miller and Dr. Barber, who are working hard and doing surgery every day. So thank all of you for joining us. And that's all we have today. Thank you.